$35,664.16 and $36,606.17. This initiative establishes one public service coordinator, one position to oversee performance improvement activities in the hospital and provides funding for related to all other costs. This position will be responsible for performance improvement and will interact with regulatory bodies, assist with plans of corrective action, monitor the hospital for compliance with regulations, and will be the lead in performance improvement activities. Pages 267 and 292. This is also a continuation of a position in LD 236. This is requesting general fund dollars in 16 of $41,875 and in 17 of $43,674. This initiative establishes one public service manager, two position, and provides funding for related to all other costs. This position will act as the director of quality and informatics and will oversee all quality and performance related activities. Pages 267 and 292. Increased funding in Riverview for state fiscal year 16 of $6,120 and for 17 $6,087. This initiative provides funding to reflect the increased cost of contracted nurse practitioner positions. This initiative provides funding for a salary increase of the two contracted nurse practitioner positions needed in order to retain one position and to fill a vacant position in the contract. Pages 267 and 293. This is continuing a request from LD 236, requesting general fund dollars in 16 of $52,781 and $54,407 in 17. This initiative establishes two mental health worker, two positions, and provides funding for related to all other costs. These two mental health worker, two positions will align staffing levels to acuity of care for patients and staff, which correspond, again, with the recommendations from the Elizabeth Jones report presented to the Courtmaster. Pages 268 and 293. This initiative establishes three Nurse 1 positions. This initiative establishes those positions to align staffing levels to acuity of care for the safety of patients and staff, again corresponding with recent recommendations in the report to the Courtmaster. Pages 268 and 293. This is requesting for Riverview general fund dollars in 16 of $109,120 and in 17 $113,257. This initiative establishes three hospital nurse 2 positions and provides funding and all other to support the positions. The initiative would align staffing levels to acuity of care for the safety of patients and staff, which corresponds with the recommendations from the Elizabeth Jones report. Pages 268 and 293. For Riverview, requesting general fund dollars in state fiscal year 16 of $316,371 and in 17 of $327,844. This initiative establishes 12 acuity specialists to support client relationships and assist RPC with reaching and maintaining staffing levels to address deficiencies related to the Courtmaster report. I won't repeat the information about acuity specialists. Pages 269 and 293. Requesting general fund dollars in 16, this is a continuation from LD 236, of $21,719 and in 17 of $22,586. This initiative establishes one office assistant 2 position. This position will be required to file confidential documents, general business correspondence, and to operate routine office equipment while assisting various director level positions. Pages 269 and 293. This initiative establishes 2 nurse 3 positions to align staffing levels to acuity of care for the safety of patients and staff, again corresponding with the recent report to the Courtmaster. We're leaving Riverview now. On page 337, within the Office of MaineCare Services. This is reducing a general fund in 16 in the amount of $3,206,083, and in 17 of $3,188,998. This pertains to medication management services, which relate directly to the evaluation, management, administration, education, and/or monitoring of medication intended for the treatment and management of mental health disorders, substance use disorders, and/or co-occurring disorders. MaineCare providers bill for these services under two sections of MaineCare policy. Section 65, Behavioral Health Services, and Section 90, Physician Services. However, the rate of reimbursement MaineCare provides for medication management is much higher under Section 65 than under Section 90. Under Section 65, when providing medication management to an adult in a mental health clinic setting, physicians, physician assistants, psychiatrists, advanced practice registered nurses, psychiatric mental health nurses, nurse practitioners, and clinical nurse specialists receive a rate of $55.77 per 15 minutes. For children, the rate is higher, $63.75 per 15 minutes of service. In contrast, a physician billing under Section 90, providing an identical medication management service under Section 90, receives $24.14 per 15 minutes. Registered nurses practicing under Section 96, private duty nursing, receive $10.58 per 15 minutes. The only difference between the medication management services provided under Section 65 and those provided under Sections 90 and 96 is the setting of the service. The department has a concern over the lack of parity between these reimbursement rates. In addition, the department wants to ensure that members are receiving appropriate behavioral health services. There is a concern that medication management services have been billed at very high levels, particularly when compared to outpatient behavioral health counseling. The department would like to ensure that for members who receive counseling as part of their behavioral health treatment, this service is billed appropriately. On the other hand, medication management is a very narrowly focused service and should only be billed when providing the very specific service described. This initiative would align the Section 65 reimbursement rate with the Section 90 and 96 rates, thereby establishing parity between settings and ensuring that providers billing for the same service receive identical rates.
Representative Kateen.
So, thank you, Mr. Chair. So, Commissioner, the concern that there's overutilization here, I mean, have there been audits that have been completed and any hard findings with respect to specific providers that they've overutilized the service?
I think partly what we are looking at this point perhaps is codes, services that are being billed under medication management that likely, at least in certain cases, should be billed under other sections of policy.
Yeah.
That is increasing certainly the amount of units of service being billed under medication management.
Right. So again, you know, what I assume that the department does, and what I know a lot of other states do when they see those circumstances, is they send their service unit or their audit team out and take a look, and you know, if they find overutilization, they make a determination of whether it was intentional or not, or how clear your rules were, or you know, whether there's provider education to be done. I mean, have you done those kinds of audits and made those kinds of findings?
Certainly. I mean, we can get you information and background on that. That is different than what is being proposed here today, which is about parity between the rates. Right. We're also acknowledging other information that we have identified in terms of increased units of service being billed. We'll get you information on any recent review.
And the other thing I'd like to understand, again, maybe we can talk about this at the work session, is, I mean, this is a pretty dramatic reduction in the rate, right? From $55 down to $10.50. I mean, the department does have an obligation to maintain access for services that it provides, and one of the ways that access is maintained is by providing fair rates and making sure that the providers that provide these services, there's a sufficient number of providers and they can survive under these rates. I mean, what kind of analysis did the department do when it determined that it needed to make this kind of rate reduction, that you would maintain the right level of service for the people who need these important mental health services?
And again, this is related to the consistency of the rate being paid based upon the service being provided, regardless of the setting of where it is being provided. We certainly have looked at that. This is one service among many that may still be provided at an agency, and we have looked at the costs, and we can provide you with additional information to support why we believe that this is an equitable rate of reimbursement for the service being provided.
I just understand that if the agencies decide they can't provide this service at this rate, is there ample provider capacity in other areas to absorb all of the people that need this service? That's the part that I think I need to understand.
Understood.
Thank you.
Representative Rotunda, or Martin, sorry.
Thank you, Commissioner. Was there a cut prior to this to those in Section 65 a year or 2 or 3 ago?
Representative, I'll have to take a look at what the historical impact has been.
Seems to me, I recall.
There's been a lot of discussion about rate standardization for many, many years, but I have to take a look at what the history's been.
See what it was then and what has happened.
Yes, absolutely.
Thank you.
Representative Rotunda.
Thank you, Mr. Chair. Good afternoon, Commissioner. I just want to follow up on what Representative Bettine was saying. I do understand the rationale in terms of the equitability of rates, but I'm focused on the impact of the people served, and just want to make sure that their needs continue to be met, and interested in knowing what the department has done to be able to assure all of us that the needs will be able to continue to be met for clients. And that's the real concern.
Sure.
It's such a dramatic.
And of course, we are equally committed to ensuring that people have appropriate and timely access. That was a great deal of the testimony that I provided around looking at wait lists and monitoring access. We are confident in our ability to maintain that. We've certainly been working, as I mentioned, a great deal with a number of mental health agencies, in particular around the rate structure for behavioral health homes, and we can provide you with additional data that continues to underscore the analysis that we've done. On pages 337.
Oh, I'm sorry. Representative Hymanson.
Thank you. I'm putting on my physician hat here and talking about all cognitive care specialists. So psychiatrists are cognitive care specialists. They don't have a procedure. They monitor medications, behavior, everything around how medication is affecting very difficult to treat disorders. The same way that other cognitive care physicians like rheumatologists, neurologists, infectious disease people do the same thing. So the amount for the physician services component for a 15-minute break, a 15-minute time period to review those sorts of disorders is not tenable to be a cognitive care specialist. And so,
it's not limited to 15 minutes. I just want to be clear about that.
okay.
It's what they're able to bill per 15 minutes.
Right, but even if you go a half hour and you're a cognitive care specialist and you're going to get, $50 for your half hour time dealing with very, very complicated patients in all of those kinds of specialties, it doesn't go far enough to keep those specialists in business.
I want to be clear, though, if there are services being provided that are outside of the defined services related to medication management, those are still billable under a different section of policy or under with a different code.
But those are not for medication management. We were talking specifically about medication management, which is all-encompassing, and generally it's very hard to deal with that in 15 minutes, frankly, for very difficult psychiatric, neurologic, rheumatologic, infectious disease issues. And so I'm just thinking about that in my in terms of a cognitive care specialist, that it just does not come up to an amount that would allow those specialists to practice.
I think perhaps if there's some way that we can provide a crosswalk of the variety of codes, and at least just have a conversation during work session about what you see as not being reflected in this medication management that you see as being absolutely a part of medication management. That might be helpful.
Okay, I look forward to that. Thank you.
Page 337. This is also within the Office of MaineCare Services, and it is proposing a funding reduction, a general fund reduction in 16 of $3,775,499, and in 17 of $3,752,287. This initiative reduces the rate of reimbursement by 10%, or Section 65 of the MaineCare Benefits Manual for outpatient services, therapy and assessments, children's home and community-based treatment, and children's behavioral health day treatment. It also represents a 10% rate reduction to Section 28, rehabilitation and community support services for children with cognitive impairments and functional limitations. Maine spends over $300 million annually on outpatient mental health services, which are services provided to adults and children in a provider's office, the person's home, school, or community. The services assess members to identify behavioral health and substance abuse issues and create a plan to address these issues. And again, I want to remind you, you've got a pretty comprehensive fact sheet with some additional data, but I'm going to highlight some of that data here in the testimony. When compared to other New England states, Maine is an outlier in reimbursement for behavioral health services. For example, individual therapy performed by a psychologist is reimbursed $88 per hour in Maine, compared to $74.94 per hour in Massachusetts and $72 per hour in New Hampshire. Similarly, group therapy and mental health agency is reimbursed $21 per hour per client compared to $16.74 per hour per client in Massachusetts, $10.28 per session per client in Vermont, and $10.65 per session per client in New Hampshire. These are just a couple of examples of the differential between reimbursement rates in Maine and the other New England states. Like other initiatives in this budget, this proposal will bring Maine's reimbursement rates close to other New England states, further enhancing our commitment to manage spending while still providing critical services.
Representative Sanborn.
Thank you, Mr. Chair. So, Commissioner, do you think that there will be some community-based services that will not be able to keep their doors open because of this? And if so, where will people go to get the services that they need?
Well, we can provide you, perhaps similar to the request that was made on the geographic distribution of community mental health agencies and the demand for services to perhaps better underscore what the current access points are. Again, this is a 10% reduction. It is based upon our some initial review of costs and associated rates of reimbursement, and happy to certainly provide you with more about our confidence in terms of maintaining appropriate and needed access to these services.
You know that last year I had a bill in because the community-based providers were very borderline at that point as to whether they could keep their doors open. So I know that a 10% cut is really significant, and I believe strongly that certain providers will go under if we make that kind of a cut. So I guess in follow-up, I'm wondering if indeed providers go under and people are not able to get the services they need, then where do you think those people are going to come out? Where are those costs going to go up in other areas because they're not able to get appropriate services?
I disagree that the services will not be available. It may be a different structure, and I can't comment specifically on whatever information you've received about the financial viability and models for the agencies, but I disagree about whether or not it will jeopardize access.
Representative Jorgensen.
I think actually the question answered. Thank you.
Thank you. Representative Rotundo.
Thank you, Mr. Chair. Commissioner, I'm looking at these comparisons of rates to other New England states, and I want to make sure that what I'm looking at compares apples to apples, and whether or not there might be other sources of funding that are involved in some of these other rates, and whether there might be state grants, for example. Are you sure in terms of what you're presenting to us that there's no other source of funding that's contributing to these rates in other states, that we really are seeing that comparison of apples to apples?
In terms of Medicaid rates, but you'd have to factor in similarly if we're going to bring in 100% grant funded, the same thing for Maine. So we would have to factor that in as well. But these are related to Medicaid.
Thank you, because I do think that's significant for really trying to get a handle on whether or not we're an outlier to make sure that we're understanding what's really reflected in those rates.
So these are Medicaid rates, and that's the purpose for this proposal.
Thank you.
Representative Percy.
Thank you, Mr. Chair. Commissioner, thank you. I have two questions. And one is there a wait list for this, for services?
There is a wait list for services that certainly, as we look at within the consent decree, is a wait list that we manage, and that is continuing to be reviewed in terms of the numbers, and we can get you additional information on that.
Do you have any idea?
And it varies greatly throughout the state in terms of providers that have wait lists and providers that do not, so we can get some additional information.
My one other question was, because we've been talking a lot about preventative medicine and keeping children at home and community-based treatment. I'm just wondering about, I've read some statistics that one night in a mental hospital will equal about a month of community services. So I'm just wondering about how much we're taking away from these community services, keeping children at home, and if they don't have a place to go for some of these issues, that we're going to end up in a psychiatric hospital. So I'm just throwing that out.
Yeah, again, consistent with what I said before, I don't disagree about the cost comparison. As I mentioned, $1,200 a night on average in a hospital stay. We don't see this as jeopardizing access.
Thank you.
Continue.
On page 339, this is proposing a reduction in general fund in the Office of MaineCare Services in 16 of $726,921 and in 17 of $867,657. This initiative proposes to eliminate the reimbursement of methadone treatment in the MaineCare program. According to the Substance Abuse and Mental Health Services Association, providing primary care to individuals with addictions enhances their recovery from substance abuse, and settings that combine primary care with addiction care help to ensure that result. Primary care treatment results in better health outcomes in contrast to back and forth referrals between behavioral health and primary care offices that leave up to 80% of individuals without care. Prevention and treatment of chronic diseases does not occur at methadone clinics. Conversely, Suboxone is prescribed by primary care providers. People with addiction require high-quality treatment from a team of diverse professionals, including specialty substance abuse providers and primary care providers. Under the integrated care of a primary care provider, members receive prevention, education, care coordination, and treatment for health issues, including substance abuse disorders. In a randomized trial, researchers compared methadone clinic-based treatment to PCP office treatment using Suboxone. This study found that Suboxone maintenance therapy is an effective treatment for heroin dependence in a primary care setting and could substantially increase access to drug treatment services over methadone clinics. Studies have shown that people with substance abuse disorders have 9 times greater risk of congestive heart failure, 12 times greater risk of liver cirrhosis, and 12 times the risk of developing pneumonia, among other health issues. Additionally, data shows that not having a single primary care provider increases the use of emergency departments, hospitalizations, and costs for MaineCare members with substance abuse disorders. There is significant research to support the fact that Suboxone is just as effective as methadone. I'm quoting from a study by Horn Gazella for the Maine Office of Substance Abuse and Mental Health Services, commissioned by in 2010. Both methadone and buprenorphine have been shown to be effective in reducing illicit opioid use. The greatest number of studies examining substance use following medication-assisted therapy intervention has shown that both methadone and Suboxone improve substance use outcomes over other types of therapy, regardless of how substance abuse is measured, and there is no statistical significance between the two medications. Currently, there are more than 3,800 MaineCare members receiving treatment for addiction at 11 methadone treatment clinics with expenditures of over $8 million just for treatment. Factoring in another $10 million in daily transportation costs, MaineCare spends close to $20 million annually on addiction treatment. In addition, there are approximately 5,000 members receiving Suboxone to treat their substance abuse addiction at an annual cost of $9.5 million. The risk of addiction and the risk of fatal overdose are both considered extremely high for methadone and extremely low for Suboxone. This safety deficit is further exacerbated by the fact that methadone treatment is prohibited from being reported by federal law to the Prescription Drug Monitoring Program. So doctors may prescribe pain or other medications that can have a seriously adverse or even fatal effect on a patient when combined with methadone. Suboxone, on the other hand, is reported to the PMP and prescribed, adding another layer of safety in the recovery process. In a recent SAMHSA report, the medical director of a large outpatient opioid addiction treatment program obtained prescription history data on all patients from a newly established state prescription monitoring program. The medical director's analysis of the data indicated that unknown to clinic medical staff, approximately 23% of patients were being prescribed significant quantities of opiates and other controlled substances from providers outside the clinic. These prescriptions potentially compromise treatment and put patients at risk for dangerous drug interactions. There are approximately 118 physicians in Maine who are publicly registered to provide Suboxone treatment, which has proven to be safe and effective. There are approximately 200 more physicians in Maine who are privately licensed to provide Suboxone treatment. Additionally, because there are only 11 methadone treatment centers in Maine, members may not have local access and could have long daily commutes or need to move closer to treatment centers for their addiction. In contrast to this limited access to treatment, there are Suboxone prescribers across the entire state. The logistical advantages of Suboxone stand in stark contrast to the danger we often see in people driving themselves at home for what is often an hour or longer trip after receiving methadone treatment. As far as access to treatment, one NITEX case study found that in an addiction recovery facility in Brunswick, Maine, in 1 month, 5 clients made an appointment for opioid dependence treatment, and with an average of 2 hours, staff had found a Suboxone prescriber for each client. One staff member added, clients did not stay in treatment before we offered this service. Suboxone treatment allows patients to take this medication at home, unlike methadone, where individuals have to travel 7 days a week to a treatment center until they can prove they will not abuse the treatment, at which point they are permitted to take home. In January 2013, the department implemented, just as a reminder, a 24-month minimum on Suboxone. The results have been staggering. We have seen a significant reduction in the number of individuals receiving a high dose of Suboxone from more than 1,600 members before this initiative was enacted to under 1,000 members today. In some, Suboxone is safer, less addictive, can be just as effective, and is better integrated into a patient's overall health and is widely considered to improve functioning and employability.
You like to read your body language. Representative Sandberg.
Logic and lies, Mr. Chair. So, my concern has to do, well, I have a whole lot of concerns about this, and I see you tried to throw a lot of science into it. I'm not so sure I buy the fact, but I'm sure we'll hear from many others. But in regards to your primary care providers, I'm wondering if you have polled your primary care providers and you know how many are willing to prescribe Suboxone, because my understanding is that most primary care practices are very full, and many of the primary care physicians do not desire to take on treatment with Suboxone. So do you have an idea how many practices or how many individuals? I know that we have 4,000 some patients in methadone treatment, so there's quite a number of folks, even if this whole thing did work, which again, I don't believe that it can or is safe. But if it did, do you really have the primary care providers out there to pick it up, and have you done a poll?
Well, we've given you the numbers of those that are licensed, that have a specific DEA amended license to prescribe Suboxone. We certainly recognize, as with any change that I'm sure you can appreciate, there is obviously a need to work closely with the primary care providers that support our MaineCare members. We're committed to helping to support that model should this legislature adopt this proposal, and we'd be working very closely and are working to engage with members today, and would certainly continue that far more aggressively should this proposal be adopted.
So you have not polled primary care providers to see if they can take on enough patients?
We have certainly provided the research that I just gave you about the number that today, and we have looked at the number of patients that they currently have and what capacity might exist. And we have, and I am expressing a commitment for how we would, just as we did with the pain management protocol, work to engage primary care providers, other providers, and their respective associations.
Senator Cates?
Thank you, Mr. Chairman. Welcome, Commissioner.
Thank you.
I think this is my 5th year here now, and I know we work very hard on, for instance, placing limits on the amount of time someone on Medicaid can be on Suboxone. We've done the same with Methadone. We've done the same with opiates. But I can't think of any occasions where we have picked winners and losers between this drug and that drug and told physicians, yes, you can prescribe this regimen, no, you can't prescribe that regimen. And I wonder about our collective wisdom to do that. Have we done that in the past that we're aware of?
Well, we certainly have a drug utilization, I'm not going to get this right, the Drug Utilization Review Committee. We have advisory committee to MaineCare that is looking at what prescriptions, what medications will be authorized. There are 17 states that do not reimburse under their Medicaid program for methadone. And we can, again, I'm happy to provide more information about that oversight and process within the Medicaid program.
That'd be great. Again, I'm talking specifically about us 186 of us, very few of whom are doctors making that decision. That's my concern. Thank you.
Senator Haskell?
Thank you, Commissioner. I have 2 questions. I have a lot of questions and a lot of concerns about this one. But I have 2 questions that for the work session you can help me. First would be, could you tell me about the relative value of these 2 treatments for pregnant women?
Sure.
And we would like to see some research around that. And the second is, you talked about the prescription monitoring program. My understanding and my information tells me here that Suboxone prescribers and pharmacists are prohibited by federal law from transmitting information about treatment or Suboxone treatments to a third party, including the PMT, absent patient consent. That was, I think, different than what you said. And that methadone clinics are still prohibited by federal law from listing their patients in the PMP. However, the clinics require their patients to permit coordination with all medication prescribers. So that seems to be a little different than what you said, and I'd like it more work session.
Sure.
If you could help me identify that differentiation between what you said and what
Happy
I
to.
understand to be the law.
Representative Grant?
Thank you, Mr. Chair. Thank you, Commissioner. And I did read through the notebook, the information you provided in addition to what's in your testimony. I mean, they're pretty similar, but your chart of providers licensed to treat and licensed to treat up to 30 patients with Suboxone is very clear. What is not very clear, again, is Dr. Sanborn's question about how many are willing. And I guess, to echo Senator Cates, I don't see anything in any of this material that indicates that a panel of physicians has signed off on this idea. And I don't have an opinion about it one way or the other. But I guess I would hope that the HHS committee, before we make this change, would find some panel of doctors who would sign off on it. I don't see that here in the material unless I've just overlooked it.
Yeah, and I'm sure you'll hear from a lot of different individuals today that will continue to inform your deliberations on this. I think it's difficult for anybody, regardless of what we may be talking about pending in the legislature, to sign on anything until they know what it looks like at the end of the day. So I'm sure that many might be hesitant until they know what the language and the exceptions and the requirements may be. But what I've offered is the commitment that we would engage in an effort to help support and ensure appropriate access.
But I guess you're not a doctor, and neither am I, and I just want to make sure that we have a medical opinion that says that this is a great way to go. And I appreciate the research that you've given us and the information. As I say, I have limited expertise in this field, but I'm looking for that assurance.
Representative Sanderson?
Thank you, Mr. Chair. I want to follow up on what Senator Cates brought up. We're not limiting physicians from recommending methadone to their patients, correct?
Correct.
We're just eliminating the MaineCare reimbursement for that. They can still,
Now, excuse
they can
me,
still
thank you.
pay. They can still, if this is how a patient would like to choose for their form of treatment, there still is the private pay option, correct?
Correct.
Thank you.
Representative Bernstein?
Senator, just a point of clarification for me, please, Commissioner. You say that there are approximately 118 physicians in Maine who are publicly registered to provide Suboxone, but then it goes on to say 200 more physicians are privately licensed. What's the difference there? I don't get that.
And again, we'll get you more information, but one is publicly making it known that they are willing to prescribe. The other is that their DEA, if I have this correct and we can get additional information, that their DEA license has been amended to allow for the prescribing of Suboxone.
Do you need an amendment on your
Yes.
license?
Yes.
Okay, thank you.
Representative Hymanson?
Thank you. I've been getting a lot of emails from physicians who ask them. And so that is something that I'd like to know. What physicians did you ask who endorsed this?
Happy to get you some additional information.
Great, yeah, if we could talk to them during, and I'm sure we'll hear about that for the work session. Because, you know, the devil's in the details. Suboxone is for mild to moderate addiction. Methadone is better for people with harder problems. There are a lot of differences between them, and they're useful in two different populations. So restricting it to one population, you have to taper off methadone completely before you start Suboxone. So what happens with that tapering? Where do people with severe addictions, what do they do while they're tapering off their methadone to start Suboxone? And where are the physicians going to come from? Because as I understand it, many who have licenses choose not to do it. There are a lot of issues that have been percolating from the medical